Good morning, good afternoon. It is let me thank you for your kind invitation. And I open this session with my presentation regarding the treatment algorithm of HFpEF in the ESC HFA guidelines. Not much to say, seemingly. This is the diagnostic algorithm of the heart failure guidelines, and you see that the patients are still classified based on their ejection fraction into patients with a low ejection fraction, a reduced ejection fraction, preserved ejection fraction when it is above 50%, and mildly reduced ejection fraction, 41 to 49% values. We have a clear algorithm for the patients with heart failure and reduced ejection fraction, but this will be the topic of the next presentations. And instead, we have recommendations that are not very strong, because based on a retrospective analysis regarding the treatment of the patients with mildly reduced ejection fraction, 41 to 49%. In these patients, and I will spend some slides with respect of them, neurohormonal modulators are indicated based on post hoc retrospective analysis of trials done in patients with an ejection fraction above 40%. So ACE inhibitors, ARB, beta blockers, mineralocorticoid antagonists may be considered, and we will see also sacubitril/valsartan. This is the first of this kind of analysis done from TopCat, and showing that spironolactone decreases the primary outcome as well as hospitalizations alone compared with placebo in the patients with an ejection fraction above 45% and below 50%. So in the patients with a mildly reduced ejection fraction, we have the same beneficial effects that we have in the patients with a reduction in ejection fraction. The same occurred in Paragon HF, where sacubitril/valsartan was compared with valsartan. The primary outcome was not significantly affected by sacubitril/valsartan. However, this pre-specified analysis based on the median values of ejection fraction showed a reduction in the primary outcome in the patients with an ejection fraction below 57%. And again, when the data of Paragon and HF and Paradigm HF were combined, you see that sacubitril/valsartan had a beneficial effect on the primary outcome in the patients with an ejection fraction of below the normal values, below 50%. And there may be also some interaction with sex, so that in females, the higher value of ejection fraction may be slightly shifted upward. But it's also important, to point out, what it is important to point out is that we have a significant result in the patients with a reduced or mildly reduced ejection fraction, but not a significant result in the patient with a normal ejection fraction. So this justifies the potential indication to sacubitril/valsartan in the patients with a mildly reduced ejection fraction to reduce the risk of heart failure hospitalizations and death. This is, however, a meaningful proportion of the patients with heart failure. This is an analysis from a US registry showing that approximately 15–25% of all the patients admitted for heart failure have an ejection fraction in the range between 40 to 51–55%. What about the patients with preserved ejection fraction? In these patients, at the time that we prepared the guidelines, we really did not have a treatment. And so we just wrote as a class 1 recommendation to screen and treat etiologies and cardiovascular and non-cardiovascular comorbidities for the patients with preserved ejection fraction. Diuretics for the patients with congestion, and nothing more. We have a recommendation to reduce body weight in obese patients, as this may increase exercise capacity and improve symptoms. And actually, this was the only trial, the only evidence that we had at that time. This is a small trial, but with significant results with respect to both peak VO2 and KCCQ, quality of life, showing that cardiac exercise training, as well as body weight reduction with diet, may improve both peak VO2 and quality of life in patients with obesity and heart failure and preserved ejection fraction. That's what all we had at the time of the presentation of the guidelines in September 2021. A few minutes after, we had, however, the presentation and the simultaneous publication in the New England of the results of Emperor Preserved, a trial including patients with an ejection fraction above 45% and increased above 40%, and with increased natriuretic peptides levels, and showing a significant reduction in both the primary outcome and heart failure hospitalizations alone with empagliflozin versus placebo. This was the first trial of medical treatment which gave significant results in patients with preserved ejection fraction. And you see that further analysis did not show any heterogeneity with respect of the ejection fraction at baseline, even if there may be a smaller, numerically smaller effect in the patients with a larger ejection fraction, but this interaction was not significant. And actually, when data are plotted with the reduction in the risk of the primary outcome versus ejection fraction shown as a continuous variable, you see that there is always a consistent reduction in the primary outcome. And in the patients with the highest values of ejection fraction, we just have a wider confidence intervals consistent with the smaller number of patients in this subgroup and the larger heterogeneity. This was shown also with respect of the components of the endpoint. And you see here when the relationship is assumed to be linear, but you see that when we have a different model with a cubic spline regression with read notes, I mean, the heterogeneity of the results is even larger. So it may be, my interpretation is that in the patients with higher values of ejection fraction, we may have patients with different conditions, such as hypertrophic cardiomyopathy or cardiac amyloidosis, that may respond and should respond differently to empagliflozin, and that in the clinical setting may be worth to detect and treat with specific treatments. However, we have a drug that is for the first time effective in overall the patients with heart failure and preserved ejection fraction. we have a drug which is highly effective and significant in reducing heart failure hospitalizations and cardiovascular death in all the patients who had an event of worsening heart failure. You see here, patients who were hospitalized for heart failure, patients who had first and recurrent hospitalizations, patients who had just an intensification of diuretic treatment for worsening heart failure. In all these kind of patients, we still have, we always have a reduction in the prime endpoint event rate with empagliflozin versus placebo. The effect occurs very early in the clinical course, as soon as 18 days after start of treatment, so the drug is effective very early. And what else? We don't have data with the dapagliflozin yet. We had data with respect of the effects of dapagliflozin on quality of life in this combined analysis of the fine HF and preserved HF. You see that across all the range of ejection fraction values, again with wider confidence intervals in the patients with the higher ejection fraction, but you see that quality of life is improved across all the different ejection fraction values. These are the results of, again, quality of life in the patients subdivided in subgroups according to the ejection fraction. And of course, we have the liver trial, which was an outcome trial. And we know that we have had a press release on May the 5th, stating that the drug was significant on the primary outcome. And we will see the results, the full results during the ESC meeting. So in conclusion, and this is my last slide, SGLT2 inhibitors have a larger efficacy in the patients with also in the patients with heart failure and preserved ejection fraction. Eugene Braunwald had this bright idea to state that they are the new statins of the 21st century. And this is likely true because these drugs, SGLT2 inhibitors, are effective, beneficial, independently from the ejection fraction. So they can be given, they will soon be able to be given to all the patients with signs and symptoms of heart failure, plus increased natriuretic peptides levels. And for the first time, we have a treatment also for the patients with preserved heart failure and preserved ejection fraction. Thank you for your attention.